Assalamu alaikum. Now, it's the second part of my postpartum hemorrhage video where I will discuss about some questions regarding PPH. Start with this question. Look at this high yield question. Uh, this 39-year-old woman, Gravida 1, para 0, 38 weeks of gestation. Okay, look at here. During delivery, placenta excessive traction is placed on the cord, causing it to avulse, and the placenta is manually extracted. Ultrasound after the extraction revealed a thin endometrial stripe. Ultrasound shows a thin endometrial stripe, and on bimanual examination, there is 1000 ml of clotted blood is expressed from the lower uterine segment. Look at this point. The uterus is soft and 4 centimeter above the umbilicus after expression of the clot. What is your thought? It happens just after delivery. It happens just after delivery. So it looks like uterine atony. So it's a postpartum uterine atony. It's a postpartum uterine atony. There is heavy bleeding, blood clots in the lower uterine segment, has uterine atony. It is the most common cause of PPH. It happens within 24 hours. So it is primary PPH. Uterine atony, its risk factors, uterine overdistension, and often associated with fetal macrosomia. Look at the baby's weight, 4.1 kg is the fetal macrosomia, and uterine fatigue, prolonged induction of the labor, and operative vaginal delivery. It is forceps assisted operated vaginal delivery. There is laceration, third degree of laceration. So looks like uterine atony, postpartum uterine atony. So it has long treatment discussion of postpartum uterine atony. We have discussed in I have discussed in my first video. Just check it on there. Okay, and the last line, this point, the uterus is soft, not written boggy, soft boggy, and fundus above, and enlarged uterus with fundus palpable above the umbilicus. If fundus palpable above the umbilicus because of decreased uterine tone, so this uterus is soft and fundus is 4 centimeter above the umbilicus after expression of the clots, looks like uterine atony. So my next question, so as it is uterine atony, eh, IV line has opened, IV line has opened, and what should be the next step? Next step is oxytocin should be given in here. In this system, oxytocin should be given. This is the chart I am talking about. I am reading it again. Postpartum hemorrhage, soft boggy uterus, step 1 uterine massage, high dose oxytocin. If not stop, then step 2 tranexamic acid. Then step 3 methyl argonovrine contraindicated in hypertension, carboprost contraindicated in asthma, and misoprostol has a slow onset of action. And step 4 intrauterine balloon tamponade, and a final laparotomy should be done. Okay, look at these 80. Look at this question. In this question, what happens? Cervix is 6 centimeter dilated, 90% effaced. Okay, she dilates quickly 10 centimeter and vaginally delivers 4.5 kg. Big babe. Okay, but problem here in following the delivery, the umbilicus cord avulses from the placenta and necessitating manual extraction. The placenta is extracted in pieces, so placenta is tightly adherent, attached to the myometrium. Looks like placenta accreta, and there is profuse bleeding. Uterus is firm, and the bleeding is unresponsive. The bleeding is unresponsive to uterine massage and uterine drug. So it's look like placenta accreta. Placenta accreta is attached to the myometrium, morbidly adherent, attached to the myometrium. Risk factor is placenta previa with prior uterine surgery. She has 3 elective surgeries. So this is one of the risk factor. DNC and myomectomy clinical feature. Ultrasound with placenta previa, normal placenta lacuna, myometrial thickening, and postpartum diagnosis is this one is present adherent placenta PPH. Adherent placenta PPH. In here, cesarean delivery first, then hysterectomy. It is called cesarean hysterectomy with placenta in situ. Okay, look at this question. In this question, 27-year-old woman, 40 weeks of gestation now. mm, 10 minutes after the delivery, 10 minutes after the delivery, placenta delivers with gentle traction. The placenta develops profuse bleeding. Bimanual massage reveals a firm non-tender uterus with the fundus at the level of the umbilicus. With the fundus at the level of the umbilicus, and pelvic examination shows a right vaginal sidewall defect. It shows a right vaginal sidewall defect. There is minimal bleeding from the cervical os, and the perineum is intact. Minimal bleeding in the os, so there is no perineal tear. So it looks like genital tract trauma. So genital tract trauma, it happened after 2 hours. Gentle tract trauma, it usually happens after operative delivery. So this patient with profuse bleeding, profuse vaginal bleeding after the delivery has PPH. The most common cause of the PPH is uterine atony, which occurs due to insufficient uterine contractility, may be treated with bimanual uterine massage and uterotonic drugs. Patients with uterine atony typically have heavy bleeding from the cervical os and enlarged boggy uterus palpable above the umbilicus. But when the uterus is firm and the fundus is located at the level of the umbilicus, no uterine atony. This patient uterus is firm and fundus is located at the level of the umbilicus, as in this patient. So it is not due to uterine atony. The next step in this management to inspect the genital tract trauma like laceration of the cervix, like vagina, perineum, particularly in patients who have undergone operative vaginal delivery like forceps or vacuum. So first, look for uterine anatomy. In uterine anatomy, the fundus or there is enlarged boggy uterus palpable above the umbilicus, enlarged boggy uterus palpable above the umbilicus, but this patient uterus is firm and it is at the level of the umbilicus, so no uterine anatomy. The next step, our next step is to find to look at the genital tract trauma. These patients' vaginal sidewall defect and minimal bleeding from the cervical os are consistent with vaginal laceration. Because the vagina is supplied by the branch of the uterine artery, which receives the 30% of the maternal cardiac output at delivery. It receives the 30% of the maternal output at delivery. Patients with vaginal laceration can have profuse bleeding, and treatment is laceration repair. So it is vaginal wall defect. Treatment is laceration repair. Okay, look at this question now. Look at here. Okay, look at this question. This patient, emergency department, vaginal bleeding. Okay, this 2 weeks ago, her it is secondary PPH, not primary. 2 weeks ago, the patient had a forceps assisted vaginal delivery complicated by the postpartum bleeding from a large vaginal laceration that will require extensive repair. Okay, okay, and discharge on the postpartum day 3. Okay, fine. The cervix is dilated and has active bleeding. Okay, hematocrit. Look at the hematocrit. Look at here. His bleeding time is higher. PT-PTT is normal. Bleeding time is higher. If PT-PTT is normal, bleeding time is higher. Throm think about von Willebrand disease, like one of the inherited coagulopathy So this patient PPH is due to von Willebrand disease, VWD. Even PTT is normal as bleeding time is higher, more than 13 minutes. So looks like von Willebrand factor deficiency. Von Willebrand factor deficiency. So platelet count and PT is normal in vulnerable but impaired platelet function causing prolonged bleeding. Impaired platelet function causing prolonged bleeding. Diagnostic study include von Willebrand factor, antigen level, von Willebrand factor activity like ristocetin cofactor activity, and factor 8 level. Desmopressin potentiate the release of the von Willebrand factor from the endothelial cell and can be used in the management of the acute bleeding for prophylaxis. Okay, now look at this question. In this question, like it has Forceps deliver active labor. Okay. Weight, the patient deliver 4.2 kg, so weight is higher. Okay. Temperature is normal. The uterus is firm, non-tender, palpable at the level of the umbilicus, so it is not uterine atony. Uterine atony is above the level of the umbilicus. It is soft, boggy. On pelvic examination, there is minimal blood on the perineal. There is large purple mass protrudes vaginally into the protrudes medial into the vagina, so it's look like vaginal hematoma. It happens due to operative vaginal delivery if infant's age is more than 4 kg. Okay, there maybe looks like vaginal mass, hypopulmic shock. So non-expanding observation, expanding embolization, and the surgery. So it is vaginal deliver. So it is vaginal hematoma. So it is vaginal hematoma. Now look at this question. Okay, look at here. Gravida 1, Para 1, Postpartum. Okay. Mm, she has second degree perineal laceration. Immediately after the delivery, for the past 30 minutes, there is increasing pain, increased perineal pain with voiding. Okay, looks like. Okay, look at here. The patient's pad contains small amount of dark red blood, no clots. The perineum and the labia majora are edematous. The laceration repairs after intact, no purulent drainage, but is tender to palpation. What is the best next step? So as there is pain, so perineal laceration give NaCIDs. So it is perineal laceration, and the second degree perineal laceration causing the immediate postpartum hemorrhage or bleeding. Okay, look at this question. So perineal laceration come on after delivery and typically causes perineal edema, pain with urination, uncomplicated perineal laceration, no fever, purulence, managed conservatively, non NSAID and cisbat. Look at this question. In here, there is heavy vaginal bleeding 10 minutes after 30 minutes after the patient underwent forceps delivery, where the baby's weight is 4.4, big baby, big 41 weeks of gestation. The abdomen is soft, non-tender, okay, palpable. This abdomen is soft, fundus is boggy, palpable above the umbilicus, looks like uterine atony. So looks like uterine atony, profuse bleeding, uterine massage, high dose oxytocin is given. What's our next best step? Next best step is to give tranexamic acid. Okay, this was the flow chart. Tranexamic acid. Okay, now look at this question. Sickle cell disease, induction of labor. Okay, BP is 70 by 40. Okay, respiratory examination, tachypnea, clear lung base. Uterus is soft, distended above the umbilicus. Uterus is soft, distended above the umbilicus, and the patient continues to have profuse bleed. Looks like uterine atony and looks like uterine atony, but the clinical feature, there is PT high, PTT high. There is from platelet is low, PTT high, platelet low. So looks like DIC. So DIC, so PPH can happen. So and the stem looks like uterine atony. So this is the significant obstetric bleeding. Postpartum hemorrhage can cause DIC. This and the in DIC, PTT is higher, platelet is low, fibrin degradation product is high, uh, D dimer is high, fibrinogen level is low. Okay, look at this question. Gravita 2 para 2 emergency department due to increased vaginal bleeding, abdominal cramping. A week ago, the patient underwent prolonged induction of the labor, gestational diabetes mellitus. Okay, complicated by intraamniotic infection and IV antibiotic. Yeah, vaginal delivery. Okay. The patient was doing well in the morning. Now looks like it's secondary hemorrhage, not primary PPH. Mm, this morning she started to bleed through the sanitary pad. Okay, increasing abdominal cramping. Uterus is firm, palpable at 6 centimeter. On speculum examination, there is active bleeding from the cervical os with the passage of large clot. There is active bleeding from the cervical os with the passage of large clot. What is the most likely? It may be retained product of conception. Retained POC. Written POC can cause heavy bleeding. Placental side involution can cause heavy bleeding. Written POC DNC. Written POC PDNC. Placental subinvolution, uterotonic, and postpartum endometritis. Inflammation. Give antibiotic. Sorry, infection and inflammation. Give antibiotic. Clinda genta. Okay. These patients with heavy vaginal bleeding, saturating more than 1 pad per hour, and passage of large clot more than 24 hours after delivery has secondary or late PPH. Risk factor like similar to the immediate onset of PPH, prolonged labor, fetal macrosomia, intraamniotic infection, prolonged labor. His baby is 4.7, so fetal macrosomia, prolonged labor. These are the risk factors like primary pH. In the most likely cause of secondary PPH is written POC product of the placenta from her prior endoamniotic infection and prolonged induction of the labor. Evaluation with pelvic ultrasound and treatment is DNC. Evaluation with pelvic ultrasound and PNC. And written product of the conception typically cause late PPH with either a boggy or firm uterus, with either a boggy or firm uterus. But in contrast to written placenta, which causes immediate PPH with uterine atony, cause boggy enlarged uterus, but written placenta with conception, written product of the conception, typically late PPH with either boggy or firm uterus. So time frame should be remembered. Okay, the final question of this PPH journey, 18 weeks of gestation. Okay, DNC ended into DNC procedure. Okay, transabdominal singleton fetus, breech presentation, 18 weeks of gestation, placenta is anterior, low lie, numerous macula, myometrial thinning, cervical length is high, the patient is greatest risk of what? PPH. That why this is placenta accreta. Prior DNC, one of the risk factor of placenta accreta, and the placenta is anterior and low lying, and numerous lacuna with myometrial thickening. Numerous lacuna numerous lacuna, myometrial thickening. These are the features of placenta accreta. So numerous lacuna, myometrial thickening is the features of placenta accreta attached to the myometrium. So placenta accreta can cause postpartumly PPH and cesarean hysterectomy with placenta in situ. So this is the second part of the PPH journey. Hope you see my first part of the PPH and then you go for this question. Hope you enjoyed.